Welcome, everybody. This is a great opportunity just to sort of informally meet more regularly than we have in the past as a group, exchange ideas. The goal of all of this is to try and improve communication, quality, safety, patient satisfaction, staff satisfaction. It's certainly always challenging in the current healthcare arena. There's so many regulatory changes. There are always the medical legal aspects that, are kind of always trying to stay abreast of. And for the most part, it also becomes, hi guys, it also becomes important because how we all communicate becomes relevant to patient communication, accuracy of communication, and so on. And so it's just an opportunity, for example, this particular forum to have this back and forth discussion. What will happen on a monthly basis, there'll be different people talking about different topics, and we can certainly send in suggestions to Jamie, develop a little database on the intranet for resources that we can look at afterward. And I think the useful thing is that the office is a reasonable size at this point, and everybody's sort of in islands, and this is a chance, 3-4 departments to share ideas and try do things differently or better or the same, or whatever we can do to increase those areas of communication, education, and collaboration. So over time there have been different questions and discussions about documentation in the chart. It is definitely a focus of quality and potential for medical legal hazard as it relates to patient care. One of the things that, and it doesn't necessarily happen in private practice as much as in the hospitals, but there's always that difficult patient or difficult provider, not necessarily in the practice, but the challenge is always, maintaining that calm, professional demeanor when you're dealing with a patient who's being extremely difficult. And patients can be abusive on the telephone about getting in for appointments, insisting on being treated over the phone with antibiotics or, preferential treatment, whatever it is, or referring providers or facilities trying to get people in here. And we see it a lot in the ERs and the hospital charting, where chart wars are quite common, and they don't read well when one provider's bashing another, or comments about the patient was just negative comments that don't read well when somebody else is reading them. So a good thing for charting, whether it's those kinds of communications or clinical communication, is always think about how it reads. If you were going to read this from another facility or office, or if you were the attorney reviewing the case, everything is discoverable today. And so how might that look when somebody else reviews the information? Is it antagonistic? Is it judgmental, prejudicial, etc., or harmful to the patient relationship? And certainly none of us should take abuse from patients, providers, institutions, or anything else, but just careful documentation. If patients are being very inappropriate, or outside facilities or labs or whatever it is, clearly document, and that's your best paper trail in the event that something occurs, or what we find very helpful, I had a woman yesterday who's been followed for a mouth lesion for a very long time. She had a follow-up appointment in March that was canceled by her. She no-showed in April, and then she comes in yesterday, somewhat complaining about the fact that it took her so long to get in. So when the documentation is there and it's clear, each of us can pull that up and say, well, you canceled this appointment, you no-showed for this appointment, we called you twice, et cetera, et cetera, et cetera, and it becomes very useful in the event that you're trying to reassure another patient or a provider, or in medical legal circumstances. So even phone calls that seem relatively innocuous, documenting the reason that a patient canceled, why they canceled and didn't follow up, or if a person has had a significant issue or significant test and doesn't follow up or no shows, that we should follow up on that scenario, or even potentially let a referring physician know that Mrs. Jones no-showed, she was coming in for a neck mass, just wanted to let you know that we can close the loop and ensure better communication and follow through. One thing that's been very helpful is making sure patients have follow-up after testing. Oftentimes we'll send patients for specific testing, and it's a CT. They may have got a phone call saying everything was fine, and they don't follow up because today realistically it's time out of work, it's a copay, et cetera, et cetera. But normal doesn't necessarily mean don't follow up or no need to reestablish a treatment plan going forward or addressing other issues. So what's been really helpful of late is when calling back patients with results, making sure they're scheduled for follow-ups, whether it's a sleep study or a comprehensive audiovestibular workup or CT imaging and so on. I know that patients assume that if they didn't hear back, it's normal. And that's also a problem because sometimes we didn't get the result. So I tell patients, if you've not heard back from us within 5 days, call, and we'll call and get the result. Don't assume it's negative. So setting the patient tone and expectation is very helpful, purely because they become the better ally in the treatment process as well. So, whether it's communication to the patient in the room, communication on the telephone, which is more challenging oftentimes and more difficult, just clearly documenting all the steps, the advice given, and so on. At one point we were finding patients would come in for hearing and balance testing that have 3 or 4 tests on 3 or 4 days. An appointment wouldn't be made by the checkout folks on this end, and so it would take quite a while to get them back in. So we're trying to tighten up those things. Sleep studies, do you come in after your initial study or the titration? And so, giving a consistent message helps there too. And just always thinking about who else is going to read that note. When you read some consults and things from other providers, some of the things that you read in there, you think, well, I might have thought that, but I certainly wasn't going to say it, because it really can come back to hurt that patient relationship or providers, practice, and so on. So other things that are problematic in a hospital environment and certainly carry over into private practice is we all have different abbreviations. And I know there's a list that's being generated, but if there's any question, what may seem very clear to one person reading an encounter note is not necessarily familiar to the next person. So trying to be as explicit as possible. is very helpful. It lessens the potential for errors, lessens the potential for medication misinterpretation or patients getting wrong doses or incorrect information. With the EMR, it's become easier to communicate interdepartmentally, and there's a lot of back and forth communication, and that's very healthy. The more communication, the better. Changes in terms of patient condition and keeping people in the loop as to updates, and that's certainly very helpful. I think, and that data, as I said, is always retrievable. So in the event of a medical legal issue, they can, really do a forensic review of that particular patient and chart and so on. So thorough documentation, comprehensive documentation, good communication is definitely important on an ongoing basis. We have a little thing from Medical Liability Mutual Insurance Company. We'll send it over. It talks about some of the documentation stuff that is helpful. But I think the other important reason for these kinds of exchanges is so that you guys can share ideas and concerns or what should we do with this and how do we improve that, and bringing your ideas and thoughts or concerns to the table as well, or what affects you in your area day to day that we could do different or better as well. So those are just some general thoughts on charting, documentation, communication, maintaining professional demeanor in those communications, and reassuring patients. And we invariably get great feedback from patients that people are really well taken care of. And you guys are the face of the office. You might spend a lot more time with the patient, and then they come in and see one of the providers for 5, 10, 15, 20 minutes and so on. You may have a lot more communication with them in between as well. And so that is really appreciated because the patient experience is invariably positive, and they comment on that a lot. And so you can do a lot to reassure, calm, and inform patients. And so thank you. We're all patients at some point, and it's valuable and helpful. And certainly, on your end as well, Danielle, I know, patients want their surgery yesterday, and why do I have to go for clearance? And he said I don't, and she said this, and why? So it gets frustrating, and you guys are the good cops, we're the bad cops. If it ever, feel free to say, well, provider X said this is how it has to be. It's not my choice, but for safety or hospital issues or to get the test done, there's certain things that need to be done. So we're always glad to be the bad cops. So any questions or thoughts, suggestions, things to implement or do different?
Is there a way for providers to actually order lab tests in the computer? Like for blood work, not just blood work, but when they do specimen testing, is like, because I know that we have the what do you call it, NextGen.
Yes.
I know that because where I was doing before is that they were able to actually order any type of special testing straight through the computer. This way you'll have that follow paper trail instead of having to write out the lab slips themselves. This way it's just 1, 2, 3 in the computer. You pull it up and say, okay, this doctor ordered this, fold up, is already signed.
So
like
you
the
mean
electronic
like a
sign.
biopsy or
So you would like print out a requisition?
Yeah.
That would be in like a quick order form?
Yeah.
That would be great, and I think we can certainly look at it. The problem, different than a hospital, is in the hospital it's like ordering an audiogram or a sleep study or a CAT scan. When it's in the practice. Here we're using third parties, so
okay.
St. Pete's, Memorial, etc. There was CBL Pathology, which was one of the labs that we were using, but we tend to use them less because our primary affiliation is the St. Pete's Health Partnership.
Okay.
And so it was a lot of extra work with CBL and not necessarily the reliability. The nice thing about using St. Pete's Memorial is everything's accessible wherever you are. But once ICD-10 is in place and up and running, that's something we can ask Karen. Can there be a template that looks like the sheet that we send to Memorial or St. Peter's to try and streamline that a little bit?
Because that'll help a lot with like the follow-ups with, you know, they had a specimen sent out. It'd be a little bit easier
we
to
have
be
a
able to
challenge
follow up.
getting reports back.
Yeah.
And that's part
it's
of the.
increased recently.
Yeah.
Oh, so just to let you guys know as well, the patient portals, the patients have access through portals to Memorial, St. Peter's, and Albany Med. So I had a patient who had a biopsy, so maybe on a Wednesday. He went on the portal on Sunday and got the biopsy result. We hadn't received anything until we called mid-Monday.
We get those calls every now and then.
Yeah.
We're like, oh, they're not back yet. They're like, really? Because I looked at them
Right.
online yesterday, and then
So
you're like,
just
okay,
explaining-
well, are you like,
Okay.
I'm not lying to you.
Right, and patients come in thinking, well, can you get my report from 5 years ago from Samaritan Hospital? Just pull it up. We're not all interlinked yet. So that becomes a challenge, and exactly that. From Memorial, it seems like it's more of a problem getting results back than from St. Pete's or Albany Med. So that's something we can review as a hospital system and take back to them as well. And if there's any way of incorporating, because why else is it important that if it's in the EMR and there's an order and so on, it's traceable and sets up a little bit of a feedback loop as well. And that's very frustrating to fill out 3 pages for a culture and a biopsy if there's an automated way of doing it. So we can certainly look at that. I honestly don't know what the answer is.
Okay.
But a good suggestion, thank you. And so, again, the importance of telling patients, even, I mean, if you're checking patients out or you guys have done testing or the patient had sleep study, call to follow up with an appointment and follow up on the testing and the treatment and so on. Just always close the loop. You know, if patients have had studies elsewhere, we can ask them to try and get them over to us or, you know, request a records release if need be.
I have a question
Certainly.
from somebody who doesn't make chart notes, but I was just curious. Should you always kind of follow the rule of what you put in the chart note should be factual and not your opinion?
Yeah.
So, you know, if somebody is not being professional like a doctor or somebody or a patient is not being kind or whatever, you can put what the exchange was but not your feeling about it necessarily.
I thought Mrs. X was blah 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 blah. You know, I agree. I mean, so that it's objective, independent, but factual.
Yeah. Okay.
Because you also don't want to take, you know, a lot of abuse from a patient where they're threatening not to come back or without being able to appropriately document that. And also if patients, I mean, some patients we've actually had to discharge from the practice because they are that difficult to deal with or that abusive, unreliable, non-compliant, and so on. So, you know, the thing that really bothers me is when patients are abusive to you guys and then they come into the room and they're sweet as pie. You know, patients should not think that they can do that because it's not right. Respectful, professional, etc. And that's kind of what I was alluding to, but that's a better way of explaining it. Document accurately and
what happened, what was said, but not how you felt about it.
Right, and sometimes you have to give it 5 minutes before you document.
Or half an hour.
That person it could have been that difficult of an encounter.
I don't document. I come out of the room and I tell the doctor that this patient said so-and-so and they're not too happy in there. I warn them before they
Perfect.
go in, but I don't document.
No,
anything.
unless it
Okay.
was a phone call, but if they're
Okay.
there and you've
Yeah.
told the provider,
Okay.
that's absolutely fine. It's also useful for the provider to know that
Yeah,
going
right.
into the room.
Yeah.
You
To the
know,
lion's
absorb
den.
the impact. And patients don't like waiting, they like to get in yesterday.
You like drive-through
Everything,
service.
that's it, and you know, it can't always be provided. You know, at one point we used to treat over the phone because there just simply was nowhere to put patients. So, you know, we've had to increase the capacity in the practice over time. And I think with, you know, this quarter will be a little bit tricky because Donna has gone, and Rob will be leaving, but we have 2 PAs here training and 1 who will be starting. So, you know, just explaining to patients that ideally and medical legally, you want patients to come in to be treated. And some patients, well, every time I call, Dr. S puts me on an antibiotic, and then you're taking a lot of flack for that particular situation. So you're the good cops, we're the bad cops. Dr. S prefers that we not do that because of antibiotic resistance, or 80% of sinus infections are viral and so on. It's difficult. And so we're trying to, you know, make those schedule capacity changes to be able to accommodate patients more easily.
One of the things that I've heard from different people who make appointments is they don't want to see the PAs. What is a communication that we can give to people? Do you have any advice, like
Sure.
what we can say to them to reassure them that seeing a PA is an okay thing?
So I think it's a little less of an issue today than it might have been 5 and 10 years ago, because PAs are such a big part of the healthcare workforce,
Mm-hmm.
and that's going to double in the next 5 years. So, but patients can be very difficult about that.
Mm-hmm.
Patients will have seen a PA before and don't want to go back to a PA, or seen a doc and prefer to go to the PA.
Mm-hmm.
So it's all over the place. But I think the thing to do, particularly for a new patient, is to reassure that patient or provider referring that there's always immediate partnering collaboration. The PA and supervising physician work very closely together. They're in the same hallway. If there's any clinical concern or problem, the PA invariably will bring the doc in, or, you know, to that visit for confirmation, etc. And very often it's a mechanism to get the patient in much quicker,
Mm-hmm.
and
That oughta-
then get them seen by a physician in follow-up or, you know, in partnership. So it's sort of the healthcare team. A very important part of the healthcare team is the PA. You know, just as the nurses and the medical assistants and the sleep lab and audiology and CT, you know, everybody works together, and if there's a problem, we have docs in the hallway ready to comment or intervene if need be.
Okay.
That was a big challenge when Dr. Gavin came here from the other practice. We didn't have physician assistants at university, so everyone was used to seeing him at their beck and call.
Mm-hmm.
It didn't matter if he had 50 people on his schedule,
Mm-hmm.
they still were seen by him. So, but a lot of, now, a large percentage of his patients' parents are fine. They know he's here. They know that if he's needed, he's here. They know what days his surgery schedule is. So they're like,
Sure.
no, as long as it's a Tuesday, Wednesday, or Thursday, and they're very willing to see the physician assistants now, even more so that they work right with him on Wednesdays now.
Mm-hmm.
So
So just
that
manage.
That's good to
was a
know.
huge challenge because he had so many parents.
Mm-hmm.
But, you know, we just
Yeah.
reassured
Parents-
him, no.
parents
And
are the worst.
pediatrics
You
is
know,
tough.
we reassured him, we're like, no, Dr. Gavin's approved them, he's right
Yeah.
here, like they just wanna know you're not throwing them out too. And I think because people have had bad, like you said, bad experiences with both, but
Mhm.
mostly in like a primary care setting, I think.
And when they come in, they reiterate, Dr. Gavin's here? Yes, he's right
Yeah.
across the hall.
Oh, really?
Yeah.
So that's
I
also,
houses.
that's also the important thing is, you know, when a patient's being roomed and they say, well, you know, the physician is across the hallway, if there's a problem or they feel that there's a clinical concern, it's no problem. But I'm glad to hear that. And pediatrics is tough. It's two patients, sometimes three.
Yes.
And can be
Sometimes
difficult.
three all
Together.
looking the same,
Yeah.
all same age, and all under 3.
No, but it's always the kid and the parent.
The mother and the father, yeah, exactly.
Sometimes there's 5 people in the room.
yeah,
But we
so,
had that happen
and-
with a patient of Dr. Kaufman's last week.
Yeah.
I specifically told him, Dr. Kaufman is here, he has no availability, however, Maggie Westbunk's working in his hall today, and she has an opening, I'll gladly put you with her. He's like, I'll take it. He got here and threw such a tantrum
Mhm.
over that
The fact
nurse
that it
told me I was seeing Dr.
Yeah.
Kaufman. Oh,
And
no, sir.
that happens a lot as well, and feel free to say, well, you know, the way the practice works is, and the provider, bad cop, you know, feel free to not have to take that either, because that's a frequent problem. But I think the paradigm is shifting as it relates to mid-level care. Good point. Any other thoughts or concerns? Suggestions? Lisa, the sleep lab
No.
Nothing?
Yeah, okay, I'm not gonna lie, there is one thing, but I don't know how to word it, so that's why I didn't bring it up. I was gonna try and do it in an email and suggest it.
Sure.
Patient education is like super, the more they understand, the less likely they are to be upset.
When they get to you.
When they get to, well, not even just be upset, just be confused. A lot of times
Right.
they'll come over and be like, I didn't know I had to stay the whole entire next day for naps. So,
Okay.
or they'll be on the phone with a scheduler over here, or somebody's picking up a call and they're forwarding it to the sleep lab, and the patient's just really confused. And I think it's because not everybody is educated on sleep lab's new to a lot of people here. So a lot of
Right.
people may not understand our process and how it works, and the time frame from beginning to end, when they schedule, when the results come in, when they're scored, when I download them, I give them to you, you give them back to me, they get scanned in the chart. It's a long time, and a lot of patients are waiting to hear it on their end when somebody here answers the phone, and these people, these guys over here, I don't know if they're aware of the situation over there, or how, not that it's a situation, but how the process is.
So that's a great point. How do we, I mean, one thing that might be helpful is to maybe have the top 10 concerns, confusions, or issues that arise.
Right.
And then we can work on them, because I think our educating the whoever orders the test, that's where that education should start, and that can be 90% of it.
Okay.
You know, this is what's gonna happen, this is where you're gonna go, within a few days you'll get this, then we'll get back to you and come back in for that, and over the next 2, 3, 4, 6 weeks, we'll get you situated. So I think we can do a lot on the provider end
Okay.
to lessen the impact of that.
It actually
This-
sounds like a good in-service,
I was
actually.
gonna say,
I think it would be a really
and maybe the providers can be at that in-service as well, because what's happening is it's new, the way it's set up, and pretty much the whole office is impacted. Checkout, the clinical side, the providers,
We get frequent phone calls for results
Yeah.
over the phone,
Yes.
and I think we
Yeah.
still have the same
So-
rule of I still tell, because we haven't been told any different, I'm like, did you get your letter in the mail? No, I haven't gotten anything. I'm like, well, when your results are finalized, you'll get a letter in the mail that will tell you what your results are, and then you need to come in for your follow-up appointment to discuss them.
it's actually a perfect,
So.
I mean,
I just wrote your name down.
I was just having for lunch, but.
So as I saying,
tell us
like,
that
everybody's on the
there's
same
sorry
wavelength.
that they'll have the results and like,
As
sorry,
we-
we're gonna invite
Okay.
myself to your meeting, you'll get so angry.
So the-
They call
So that
and
needs
they're
to be
like,
relayed to the night staff. But these are the things that I'm talking about, like, this is
Yeah.
really good here, I'm really, I like this because it
We're sitting
happens
over there
every
not
day.
knowing, you guys are over
So
here
we
not
kind of
knowing.
just
Yeah,
followed the same
it's not fair to either
guidelines
side.
that we had when you weren't part of our practice.
Yeah,
Right.
no, this is really
I
important
do
because
like
you
that.
talk about patient satisfaction. I mean, it could be so frustrating calling here, being put on hold, somebody else picks up the phone, it's a sleep lab issue.
You get
So
bounced around.
these meetings
Goes to
are
sleep
just,
labs,
you know,
another
monthly
issue.
or more often because communication is great.
I even think it's good for any of the departments, like us, the receptionists, us, the nurses.
Absolutely.
Because we seem to, interact together. And
Right.
there's always a little issue here or there or whatever, and it's never,
All of our jobs
Yeah.
affects each other.
Right.
That's it, and you may not have
Affects the
thought of
patient
something
experience.
and then
right.
you did
And being together, we can vent it
Very
and
helpful.
talk about
I
it, rather than having the supervisor go to them to tell them what, so-and-so or
I
the
mean,
group
I'd be
said.
happy once or twice a month just to do a general, this kind of general, whoever would like to get together.
Mhm.
I think it's helpful.
Absolutely.
So we were just talking about communication, patient satisfaction, the different parts of the office, etc. And Lisa brought up a good point. Now with the sleep lab being integral, workflow as the patient perceives it to lessen the back and forth and frustration and so on. And then, this is probably the best facility in the state, if not half the country. I mean, it's state of the art, and it's a wonderful sleep lab experience. But there's so many moving parts, and to improve patient perception and satisfaction, timing, when they're going to get this and that, and who they should call, and maybe those calls shouldn't come to the general office, they should come directly to the sleep lab
Which
and
I had the sleep
have a
lab
little
added
card.
to the tree.
If you have sleep lab questions, here's your contact information, or
This is like,
some way of,
I hear Laura even scheduling, or explaining surgery and whatever. That's another idea for you as far as having it written down, because
Yes.
even when you talk to a patient, they're listening to you, but they're not really.
Right.
so maybe
So I think
that's
the education
another thought,
within
maybe
the
like,
practice on the employees is
Right.
really important, because they're,
Right.
if they may answer the phone, they're also trying to educate the patient, and they can't really
absolutely.
convey
And-
that
and
if they really don't know what the
Right.
process is either.
And you wanna look like you know what you're doing.
And
That's it,
sometimes
if
I'll
it's
get a patient-
streamlined
Yeah.
and efficient,
10, 15 times a day, okay, maybe that's a little, a handful at least a day, we get phone calls, and they're to schedule follow-ups with providers.
I say.
Because,
We get them all day, every day.
yeah, and it's
More
like,
than 5.
After sleep testing.
I'm not gonna bounce that patient back over. I feel
Right.
terrible, so I'll just schedule the follow-up. The problem is I don't have the ability or the know on each provider's schedule,
Right.
as well as these schedulers do, or they can kind of finagle the schedule around to get that patient in, cause their RDI is 110 and they just don't wanna
Sure.
come in for CPAP without, do you know what I'm saying?
And
Where
then
I'm
the-
looking at your schedule and I might be booking out until the end of October, earlier November, whatever your schedule is, and they're not gonna wanna wait.
And the other
So-
thing is, like you say, we'll say, come back, if your first test is positive, we'll see you back after the CPAP titration. Some patients, no, we decide we want to come back in between.
Yeah.
We don't know
Or
if
they
we
set
wanna
up
do
to
that.
come back in between, no, we want to come back.
Yes.
So there's so many moving parts, so maybe that's a great place where, with you guys scheduling the clinical side, Siobhan, we can just figure out a flow, maybe a 2-page, this is what to expect in your sleep experience. Contact this number for an appointment, this number if you have questions about your study or the sleep lab,
So like a
maybe
guide.
like a
It would
guide,
even
like
be
we
good
have for
reference for
allergy.
staff.
And then cut
That's
down on
exactly
phone
what the point
calls
I'm
coming in,
Absolutely.
You know?
Because we do
Absolutely.
provide that to the patients when they come over to schedule, but the staff would at least help them say, okay, well, you've already gone to this point.
Mhm.
Now you're at this step, and this is where I need to send you or transfer you, or what I can do for you. And we kind of talked about that a little bit this morning with David, for your patients and Dr. Daly's patients, or Dr. Adelson's patients.
Yeah.
It would eliminate a lot of the back and forth
Yes.
redundancy, and we'll
Yes.
hold on, we'll get you, and hold on, we'll get you, and I
And
think
it's
that would,
helpful for all of us, and even you guys. Sometimes I'll get a phone call and I'm not sure, do I give it to the provider? Do I give it to a nurse? Do I give it to a scheduler?
sure.
So sometimes I'm sending it to the provider and the scheduler because I don't know who needs
And I
to
might
do it.
suggest as well, in that flow and patient information, some information about what to do with download data. You know, because patients call and say, where do I take my download data? Or they show up at the front desk and they've got their card, or, you know, so, that's a frequent one too.
Yeah, that one's a little tougher because, right now, the only ones that we are directly collecting are the ones we set up. You know, like we
Right,
have all these
right.
patients who, all the other insurance carriers other than CDPHP, you know, who, they have their 3-month requirement, you know, to fulfill. And then you
Sure.
might also be getting data if they're having problems, or just a routine, you know, yearly kind of check. But yeah, it needs to be scanned in and probably put in through the PAQ.
We get a lot of tasks from the providers that say, you know, your AHI is blank, 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 good compliance, good results, continue,
Is,
continue.
is this
I had
vegetable
suggested, can we just put
That's
like a
pepperoni,
formal
it's
letter
not
to
sausage.
May I have
to
a
mail to them,
slice of
say, we got your
vegetable,
recent data
please?
download information,
I
your
don't know where the,
AHI,
things
whatever.
Oh, that's fine, just break it for corner. no
Instead
problem.
of calling them all,
Thank
like,
you.
we have to call them all, we get tasks for those, and we have to call all of those people.
For your data downloads?
So that's where we could
Pardon my hands,
streamline
but I'm
things,
holding
because
it back.
also technically then